Hello and welcome to the AEMT lecture series. Welcome back. This will be video number 1 for chapter 24, Psychiatric Emergencies. So here we go. Okay, just the standard competencies here. Be able to recognize a psych patient and then be able to assess and manage the psychiatric emergency. So let's talk about it. I think I want to say it but a different way, but one of the ways to really get in trouble is to misdiagnose a patient as a psychiatric emergency and that patient have a true medical problem. I think that's the biggest. We have to be able to recognize the difference between a medical condition and a mental illness. Now, it's not as easy as what you think or as most people think. There's going to be a time in your career where you're going to have a patient who's going to present like a psychiatric patient, and they're not going to be psych. They're going to have an underlying medical cause. And that's what we're going to talk about today. And just some myths versus reality. Some folks think that, everyone is going to have some type of emotional crisis. It's not always true. Not everybody has an emotional crisis to the point to where they'll clearly meet the definition of a psychiatric emergency. If you're feeling bad, you're necessarily sick. And not always true. There's many reasons out there for feeling depressed. One of our biggest challenges, though, is because we don't know this person. This is the first time we've ever met, so we don't know their behavior. We don't know what has brought them to calling us or what has brought the family to calling us. So we need to know, is this patient going to become violent? Okay. Because that changes the whole ballgame. If somebody's going to become violent, we need to protect ourselves. And that's always priority number 1 is yourself and your team. Let's talk about how we define this. So what is behavior? Well, the definition of behavior is really what society thinks is normal behavior. Society would not think too kindly of me walking nude down the hallways of headquarters. That would not be considered normal. And so I think that's, what we have to understand is, number 1, normal is defined by society, not necessarily an individual, but society as a whole. Okay. Normal can be, and that's defined by our society. A different society may look at behavior completely differently, like different cultures. So abnormal behavior, again, would be the tendency to deviate from normal. And normal, again, is defined by society. So if this abnormal behavior is a pattern over the last month, and it becomes a matter of concern from a mental health standpoint. So we're looking like, and we're going to talk about these disease factors here in a minute, but chronic depression, right? It's a medical diagnosis, someone who just persistently feels sad. The person who's suffering from that may fall into a category where they're able to respond appropriately. And then you need to know what defines a psychiatric emergency. So this is a patient who shows agitation or violence, and they can become a threat to themselves or they can become a threat to others. These psychiatric emergencies are more serious than a typical some of the other emergencies. And that's because of legalities that we're going to talk about. So mental health, I mean, it's a huge problem. It's an absolutely huge problem that we have not done a very good job in our country of dealing with. And I'm sure most of you guys who've been out there in the field for some time will agree with that because of the number of calls that you're running on that. I've been to many group homes that were set up as mental health group homes that were crack houses. Previous to this, like in the 80s, early 90s, and then before, we did a terrible job of it too. We didn't see it as much in society. And the reason why is because you had psychiatric institutions where basically if Johnny had ADHD and just wasn't behaving, could be diagnosed with some psychiatric disease process and dropped off at this institution where they received really nothing. I mean, they would get meds and that would be about it. And they would just continue to deteriorate, not because necessarily of their disease process, but because the psychosocial that went with that. And the things that they saw in these psychiatric institutions were terrible. So now those psychiatric institutions are, I think at least mostly out, if not all the way, meaning you don't have an institution holding 550 people with 5 or 6 staff members dealing with that. I think that day is gone. But what the answer to resolve that was outpatient care. And outpatient care, once the patient is out of crisis, they're released to outpatient care. And there they are. Where do they go? And there's already a cognitive problem, so they don't do very well at scheduling outpatient care. They don't do very well at mitigating insurance and all of that. So basically, they don't get a whole lot of help. That's kind of where we're at today. A lot of the disease process can be caused by social, psychological genetics. Depression sometimes has been, depending. Most studies show that depression, anxiety is genetic. There can be physical factors. Okay, there can be chemical or biological disturbances. There's many factors here that can lead somebody down the path of mental health issues. So the path, though, of abnormal behavior. Okay, so let's look at that for a second. So sudden grief, any of these on the screen can cause some type of abnormal behavior or altered mental status. altered mental status is more than just patient can respond to verbal pain. Mental status, how they're behaving, if they're altered in that. Recent trauma, it could be psychological trauma. It could be like recent head trauma that can cause this. Drugs, alcohol, exposure to heat, cold. Not just that, a lot of, what's the word I'm looking for? A lot of electrolyte disturbance, sodium, potassium, any of that stuff, a lot of your chemistries in your blood, if they're off, can cause altered mental status, can cause behavior issues. And let's don't forget about Alzheimer's, dementia, grandma, who never said a cuss word in her life, can't stop cussing. That's, because of Alzheimer's. Hypoglycemia, that's the big one, really, because it can mimic a stroke. It can mimic a behavioral emergency. Low blood sugar can cause all kinds of problems. Hypoxia is another one. We talk about it, and we'll talk about it in trauma, but the patient, 3 or 4 patients in a vehicle, high-speed motor vehicle collision, you have an open femur fracture, you have a couple other ones, and then you have that one patient in the car who's not saying a whole lot, and they're kind of agitated. You ask them, hey, do you have any allergies? No, I don't have allergies. Okay. All right. Do you have any medical problems? No, I don't have medical problems. And they're just real snappy. You would consider it rude, but it's not. They're probably suffering from some type of internal injury, and they're bleeding. They're in shock. So a lot of times that can be perceived as a psychological. It could be perceived as a psychological emergency. Okay, so then we talk about organic causes, but remember, we're not there really to diagnose an underlying behavioral crisis, like, they're paranoid schizo, or, this is major depression. We're not there to do that. That takes quite a bit of work on the medical side to kind of get that diagnosis. We need to distinguish, is this a behavioral emergency or is this a medical emergency? And if so, how do I treat it? That's really, at the end of the day, that's what we need to decide. And then during that decision-making process, we need to decide, is this patient suspect to become violent? If so, I need to protect myself. I need to protect my team. And then there's a definition called organic brain syndrome. Okay, it's temporary or permanent dysfunction of the brain, and it's caused by, disturbance in the physiological function of the brain tissue. Okay, so this could be from like a sudden illness, like bacteria meningitis, right? This could be secondary to a recent head trauma. Maybe the patient was involved in an MVC, 6 months ago, and their brain tissue is recovering. This can also be caused by drug and alcohol intoxication or overdose. Other diseases of the brain, I already mentioned Alzheimer's, right? I talked about hypoxia. I've talked about, inadequate blood flow to the brain. Some of your environmental emergencies, like excessive heat, excessive cold. All right, and so what we have, so if a patient, and we're still talking about the pathophysiological section of behavior. Okay, so these patients, at the end of the day, they meet the crossroads. Okay, and some well, not all patients meet the crossroads, but some do. And there's really only two ways to deal with this from a patient perspective. So one, they come up with some type of coping mechanism to deal with it. Okay, so like patient may have suffered years of child abuse, right? Now they're adolescent, they're coming into, that age group, or maybe, they're suffering from clinical depression or whatever the behavior is. There's two options. And one of them is those coping mechanisms. Maybe when they start thinking about the past and how bad it sucked and all this, they have a coping mechanism where they think, okay, I just thought of something bad. I'm going to think of something good. I'm going to think of something that's going great in my life right now. I'm going to think of something that makes me happy. Okay, that's a coping mechanism. But the second is escape. Okay, so escape can mean a bunch of different things. Escape can mean removing yourself from that stressful environment. But it could also mean escape through drugs and alcohol. I don't feel when I take these drugs, or if I drink too much, it helps me to forget. Helps me to forget about the bad things. Escape could mean suicide. I'm going to kill myself and escape this terrible situation that I feel like I'm in. So when you're dealing with behavioral emergencies, think like that, because they may be at one or the other of those. And if they're at the escape part, that's when, they really need our help the most. I'm just checking my notes, make sure I covered all this. It looks like I did. Okay. So we have functional disorders, right? And so that's one in which the etiology that can't be traced to an obvious change. It can't be traced to like a structure of the brain. So basically, it's just like an unknown. We know that this person has a behavioral issue, right? But we don't know why. We don't know exactly what part of the brain is misfiring, but the patient definitely has something going on, and so we can take some other signs, and then we can start pointing to something. We'll talk more about that here in just a few minutes. But yeah, so we can't define it. Something's gone wrong, but the root cause, we don't know. All right, and some of these disorders that act like this or that look like this, schizophrenia, anxiety conditions, and depression. So this is kind of a good way to look at it. So the physical symptoms, okay, signs that reflect the body's attempt to maintain a balance in the face of physical stress. So think about it like this. I want you to think about like homeostasis. All right, and so the body responds to blood loss by vasoconstriction. All right, so if we're bleeding out, the body starts vasoconstricting in order to survive. Well, you still have these same survival concepts. The body still wants to maintain a certain, in the middle of homeostasis. It wants to be normal. The body has its own version of what normal is. And so it's going to present some signs and symptoms to us, the medical provider, that it's coping, that it's trying to cope. Just like a vasoconstriction, we can see that in the diastolic blood pressure. we can get an idea of patients trending, their diastolic is trending higher. So we go, okay, they may be in shock, they may be bleeding out. So we can look at that person's mental health, and we can understand that it's challenged by these mechanisms or behaviors. All right, and so they can be these symptoms will present as signs to us that can be grouped according to the system they affect. And if you look at table 24.2 on page 1013 at the bottom of the page, it'll list these. It'll list these areas, or I'm sorry, these systems that they affect. And so it's broke out to thought, affect, memory, orientation, and perception. All right, and so we can see if those areas are altered, and if they are, then we can start associating that maybe this patient has a behavioral emergency. All right, so let's talk about the scene size up, because it's a little different on a psychological call. Okay. It's a little different, and it's different because when you start cueing in to this patient's psych, I think this patient's psych, I don't know, I'm starting to put it, I'm fixing to add it as a differential diagnosis. You know, it could be this or it could be this, and I'm starting to put psych into this picture. I'm bringing it in, right? So we need to be very observant to their environment at that point. Okay, so we need to start looking at the overall general appearance of the patient. We're going to start making some assumptions here. We're going to look at how is the patient dressed. Now, we want to know, we don't care, you know, like, I don't care if their clothes match. I want to does it look like that they've been wearing this outfit for 2 weeks? Okay, how does the patient present cleanliness wise? Okay, do they look like they've been unkept for a period of time? Okay, let's start looking, because sometimes you'll ask psych patients, you know, what kind of medicines are you taking? And so, you know, they start throwing out some names of some antidepressants or some anti-psych drugs. Then you can start putting it together. But a lot of times they'll say, I'm not taking any medicines. And they may not be lying. They may be off their meds. Okay. Then sometimes you'll ask them, you know, okay, well, are you supposed to be taking medications that you're not taking? And sometimes they'll continue to tell you, no, I'm not taking any medicines. Look around. You might see a medicine bottle somewhere, and sure enough, when you pick it up, it's got their name on it, and it's got, you know, it's an anti-psych drug. And then you go, okay, well, maybe they do have a psychiatric history. And so you can start looking at that. But we also want to know this for the hospital, because if the house is trashed, the patient's in an unhealthy environment, we need to get social services involved. You know, even after this patient may go to a psychiatric facility, but once they are no longer considered a psychological emergency, they're going to be released. And somebody needs to follow up with them. They may need help at the house getting things together, right? So we have to look for that kind of things, because when we go to the hospital and we're turning this patient over and we say, this is Mr. Jones. Mr. Jones is 38 years old. There's no history, no meds, no allergies. All right. So, but if we can find a couple of meds, that'll open it up and the patient will actually get care quicker. Scene size up also goes without saying. We got to make sure that we're going to be safe. All right, we're looking around that scene. Once we start thinking psych, your spider senses should start going up. Do I see knives around here? Is there anything this guy can pick up and throw at me or hurt me while I'm trying to remove myself? Those sort of things. Your general impression is kind of what I was just talking about. You want to start looking for those signs of aggression. You can see it in their body language, right? You can start seeing threatening body language. They can start using verbiage. I don't start feeling too threatened though until I start seeing that body language. They're standing up, they're trying to invade my personal space, or their hands are maybe they're clenched like fists. Those are big things that I know, okay, this scene is getting a little bit too unsafe. I need to remove myself from it. We're lucky enough here in our department, we have MDTs, and we can look at a few things, previous calls to that residence. We can look at, sometimes it'll be flagged as a dangerous place. So we can look at some of the comments. So that helps us out a lot. If you get a complaint, let's say it's December and the complaint is the patient's been bit by a snake. Well, there's not a whole lot of snakes crawling around in December that are biting people. Okay? I mean, I'm not going to say it doesn't happen, because sure enough, one of you guys has been bit by a snake in December, but not many, right? That should start cueing you in to, wow, this is weird. And it might cue you in a radio. Go ahead and let PD respond with us. Let's go ahead and get PD on this and get them started this way. Okay, on a behavioral crisis call, too, don't get in any hurry. This call, you're not going to resolve this quickly. So don't rush it. Take your time. And because that way you can start looking for the important signs of aggression. You can start looking for everything we've talked about so far. And you have to continuously stay alert. These patients can flip on a dime. And 1 minute they're your best friend, next minute they're trying to whip you, trying to beat you up. Respect their personal space. A lot of times they will refuse assessment. Okay. A lot of times though, after you talk to them for a little while, they'll say, go ahead and check my blood pressure. Then you're making progress with the patient. And reduce the drama on the scene. If there's people in the room, say the family called you and the patient is mad as all get out at the family, separate them. Have the family go outside. Let them know, hey, we're going to talk to you in a few minutes. Maybe you send Cap out there to talk to them. Maybe you send somebody out there to get their side while you're getting this side. And the least people that the patient can draw off of, the better. When they're talking to you, are they making sense? Okay, are they putting their thoughts together rationally, right? When you're asking about medications, are you taking medicines? No, I don't. When I was 6 years old, I took medicines because I had a fever. Wow, here we are. Really, what? So yeah. Thought pattern is all over the place, right? So that's the kind of things you're looking for when you're assessing your patient. We're always going to consider ABCs. That's just what we're going to do. We're always doing that. We can do that from talking to the patient. But I will tell you this, don't get, and a lot of times you can determine by the scene, by how the patient's talking before you even start to get to the vital signs that this patient's really acting like they're psych. We still need to do an assessment because of why? Again, hypoxia, patient could be low blood sugar, that sort of thing. So we really need an assessment, but we don't have to rush it. The quicker you try to get that stuff done so you can get back to the station, the more agitated your psych patient's going to become. So slow down your process a little bit, a lot of talking, a lot of getting to know the person, a lot of listening to erratic talking and erratic stuff and then bringing them back to where we're at today. A lot of that's got to happen. History taking, and this, like I said, is important. Let's try to get as much history as we can. The patient may, I don't want to say lie, but lie a few times. But then, for every lie, sometimes you get the truth of something else. The more you talk about it, and don't try to get the answer right away. You might start talking about medical history, and you get nowhere. You talk about something else. You come back. So really, you don't have any medical problems? No. And then you come back to it again later. I was thinking maybe you had this kind of medical problem, and bring the conversation back up. And eventually you may get somewhere like that. When you're trying to evaluate for the suicidal ideations or harm to others, there's no real polite way to ask. I used to, when I first started out, I felt like, man, it's rude to ask somebody about suicidal ideations or all that. But no, it's not. It's not. And if the patient's actually suicidal, they may want somebody to ask them about that. So, hey, you ever thought about killing yourself? No? Okay. Depending on how they respond to that, okay. They may say no. And very commonly then, well, what about harming others? You ever thought about that? You ever thought about hurting so-and-so or this? You can utilize some folks, and then there's folks you can't utilize. It depends on the patient, honestly. It depends on what the patient is responding to. If he's responding very angrily to family, get him away. If he's seems to be getting along with family, okay. In my experience, that if there is a bystander there, and there's 4 or 5 of them, there's one that the patient likes, and the rest they could care less for, at least in that present moment. So the best part, though, is to, if you do have somebody knowledgeable on the scene, is to be able to collect a good history. So the patient, let me give you an example. Say the patient was treated in, I don't know, South Georgia somewhere. South Georgia, some crisis center down in South Georgia about 3 weeks ago. All right. But the patient's really not releasing a lot of information, and you're getting some information from the, important bystander, right? Get the name of that place so that once you do get to the hospital, you can pass that information on, and we could Google the name of the place and get the phone number, call down there, speak to the right people. We could get the whole story of what's going on, that answers all of our questions. But if you don't get that information, then I don't know it. At the hospital, I wouldn't know it. When you are taking history, like I said, how can I say this? Because I've been there. All right, I know what it's like. It's 2 a.m. and you're dead. You're dead tired. Or maybe you just are having a bad day, right? I mean, it happens all the time. If they're rambling for 10 minutes about when they were 5 years old, it's important to let them ramble about when they were 5 years old. At least look at them and act like you're paying attention. If you're not, that's fine, but at least play the part, because that goes a long ways. Because after you sit there and listen to that, and listen a little more, even if you're not, you're you look like you are. That goes a long ways, and then you could come back with a follow-up question, and you might get an answer because they're thinking, well, this person, he's actually listening to me, because most people shut it off. They don't listen to crazy talk. They're like, I don't know, whatever. But no, don't do that, because it goes a long ways. It really does, and it's those little things right there that stop the patient from becoming violent. It stops the patient from doing a lot, and they'll cooperate with you. All right, so let me go back, though. Let me back up because I can't say it again. It's so important to make sure this patient is not a medical patient. So we need to find out, is this a CNS problem? Is their CNS function accordingly? Is there evidence of substance abuse? Has this happened before? Has this patient had a psychiatric episode before? And if not, and they're 45 years old and this is their first episode, it happens, but, that should be like a warning sign. Maybe this is something else. And then the secondary assessment, this is where your vital signs come in. This is really important because if it is, a hypovolemic type thing where the patient's not getting enough oxygen to the cells, including the brain, then we may see their blood pressure low. We may get their blood sugar at this point, find out it's low blood sugar. This is a very important thing to do. Oops. And then reassessment. All right, let's talk about this acute psychosis. All right. Acute psychosis, I was just thinking, this is somebody that they could appear manic. They're extremely happy. They've used some type of mind-altering substance. They're schizophrenic maybe, and they're manic, and they're just all over the place. But their general mood is up. They think everything is normal, but it's not. It's anything but normal. But some causes of these psychotic episodes, is like schizophrenia. Your patients induce stress, and remember what I said earlier about those signs of the body trying to maintain some type of normalcy. This is where you start seeing it. The body's reacting, trying to maintain normal. And the patient may have been under like super intense stress, etc., and you're starting to see that. Some of these patients, though, may be belligerent, they may be angry, just depending on their level of manic. Then we start talking about the disease processes like schizophrenia. It's not easily defined. It does usually start early adulthood. Sometimes those symptoms can start early adulthood, disappear, and come back strong. But delusions, these are your patients that feel like, somebody's living in the next room, next bedroom, and nobody lives with them, and this person's recording them. Stuff like that. They're having hallucinations. And it could be audio meaning you're hearing voices, or it could be visual as well. These patients, they ramble, they're incoherent. Let's talk about this coast map. C for consciousness. Orientation, all right, when we're talking about orientation disturbances, more common in organic disorders. A for activity. Okay, so most commonly accelerated with agitation. They can be hyperactive or diminished. Their speech may be pressured or sound strange because of unusual words the patient has invented. Their thoughts disturbed in progression and content and may show any disorders like flight of ideas, with the patient's mind plugging from one thought to another. Delusions. Okay, then we have memory. It can be relative or entirely intact. A for affected mood. The mood is likely to be disturbed by psychosis. And then perception. They're auditory hallucinations or one or the other. They're common. Yeah, anytime you can get somebody to go to the hospital with you to be assessed for this without using like a pharmacological agent, we like that because there's always risk in giving somebody ketamine. There's always risk of giving Haldol. We prefer not to, but we have to sometimes. Suicide. And don't forget suicide or suicide homicide. I had a friend of mine, it was an old partner of mine, it's suicide homicide. He killed himself and his family. And I never saw it coming. I never thought that he would do that. It was crazy. He was in public safety, obviously, with my partner at the time. But we had been partners. We'd partners for, probably almost a year when this went down. But yeah, it was sad. So it happens. And sometimes you don't see it, but if we can see the warning signs, then we need to try to deal with that. Does the patient have are they tearful, sadness when you're talking to them? Do they show despair, hopelessness? Are they avoiding eye contact? If they're not talking about the future, maybe you ask them something that would respond to the future. So, we got any, trips planned or, and they just don't ever talk about the future. Then we have agitated delirium. And so this is an impairment in a cognitive function that can present with disorientations, hallucinations, delusions. And this is all stuff that you guys covered in EMT school. I'm just hitting the high points. Don't forget these patients have the right to refuse care if they're alert and oriented to person, place, and time. You know that, though. If we're going to restrain somebody, a couple of things. One, you need to at least have 4 people there. At least 4 have to be there to restrain somebody. There needs to be a plan in place before you do it. And there needs to be something like a safety officer, somebody to kind of oversee it that's not actually involved in the restraining process. You can use restraints to protect yourself or to protect others from bodily harm or to prevent the patient from harming themselves. That's the only time you can use restraints. And there needs to be some type of chemical restraint used as well. You'll have to call for an ALS unit for that. And guys, that is it for this chapter. So study up, and I will see you guys on the next chapter.